This is Dr. Swaroopa from RITU'S Advanced Skincare. Today I would like to tell you how to get rid of pigmentation. That is, there are different types of pigmentation wherein we can wait for some time to get rid of them spontaneously, or it may be certain tough types of pigmentation which definitely require treatment. So usually pigmentation could be genetic, like which is called which comes congenitally or which can manifest later in the life, and there are also certain conditions wherein some hormone abnormalities like Addison's, Cushing syndrome, and any adrenal tumors and any other sort of different endocrine issues which can secondarily cause pigmentation. Also, there may be physiological conditions like pregnancy or intake of any medicines like oral contraceptives, antipsychotics, which can also cause pigmentation. And there is also another condition called melasma, which is definitely a tough to treat condition. So we need to diagnose, like we need to know which under which subtype is our the pigmentation that we are suffering from, and accordingly we can wait or just take the treatment for it. So usually for freckles, as we mentioned, for congenital conditions like freckles and lentigens, actually the best thing we can do is only sun protection, because for lentigens we can't treat them, because whenever it's like what we say, it's a permanent thing, and whatever we can do is use sunscreen so as to prevent further occurrence. Like in freckles and lentigens, as we know, freckles occur in sun exposed areas, and wherein lentigens can occur in any part of the body. So it is not related to any sun exposure or so, and it is also associated with underlying conditions like some intestinal polyps or some other systemic abnormalities will be associated. And coming to the physiology, which is actually helpful for us, we know that there are two layers in the skin, which is epidermis and dermis. And these melanocytes, which we are talking about regarding the pigmentation, which cause this pigmentation or which give a color to us, is the melanocyte. And because of this melanocyte, we have the skin color. And these melanocytes are usually situated in the basal layer, which is the lowermost layer of the epidermis. And each melanocyte it supplies the melanin to 36 keratinocytes surrounding it. So this ratio is fixed in any race, whether you are an African or an Indian or a European. So it doesn't differ, the number of melanocytes do not differ, or it is not the increase in the number of melanocytes which is responsible for the pigmentation. In Africans, pigmentation is high because there is more branching, more number of melanosomes which actually contain the melanin content in each melanocyte. So it doesn't depend on the number of melanocytes, the racial differences of the pigmentation, they don't depend on the melanocytes. They only depend upon the content of melanin which is present in the melanocyte. And these are stored in melanosomes. And these melanosomes are dispersed to the keratinocytes. The faster the rate of dispersion, the more dendritic branches are present in case of these melanocytes, and depending on the external conditions like exposure to increased sun exposure, and these will decide the amount of melanin content in the body. But in conditions like freckles and lentigens, that is a different scenario, wherein the lentigens they contain more number of melanocytes as well as the melanosomes, and these are congenital conditions, and they are usually associated with some systemic problems. So these conditions are little difficult to treat, but even though freckles and all, we usually use sunscreens and even some procedures like some cautery ablation, and we do, and even if they don't respond, we go for lasers. And coming to normal conditions like psoriasis or any lichen planus conditions, wherein other skin conditions, they usually heal with some pigmentation. This is because some unknown condition. These are all autoimmune conditions. So we don't know what is the reason behind it, but this is the melanocyte in the basal layer which is getting disrupted due to some unknown inflammation. And these melanosomes, they gradually segregate into the lower layers which is in the dermis or just above the surrounding that basal layer. And what happens is there are some skin macrophages which whenever there is some material which is disrupted into the dermis, they usually engulf and remove them. So by the time they remove, there is some pigmentation. Like there is some time wherein after you get a hurt, or in case of psoriasis or in lichen planus, so when the lesion is healing, you have some pigmentation, and this pigmentation will be there until these macrophages or Langerhans cells, they are called, which are present in the skin. The macrophages in the skin are called Langerhans cells, and so until they engulf this material, this pigmentation is seen. So in such conditions, we can wait for some time. Like you can use some creams which are depigmenting creams, can be used, some sunscreens can be used so that to prevent further hyperpigmentation. And in such conditions, we can wait for some time and use such certain creams which will be helpful, and in these conditions you don't require any major procedures. And there are also certain conditions, even after a hurt, after you get hurt, there is some pigmentation around that patch, and even that will heal. But conditions like hormonal conditions wherein your person is taking oral contraceptives or any other antipsychotic medications, they usually have some pigmentation on the body. Sometimes it is because of only in the sun exposed areas, because there are certain metabolites which are released in the process of the metabolism of the drug, and that is sensitive to sunlight. And so when there is sun exposure in the sun exposed areas, you have those deposits. So in that conditions, you need to avoid those drugs, and this will definitely help improve the pigmentation. So depending on the underlying condition, you need to treat. So a detailed history will be taken from the patient regarding the medicines, the underlying skin conditions, or any hormonal issues, like as in case of melasma. So we have, there is a pattern of pigmentation when you have pigmentation on the cheeks, on the forehead, nose, on the upper lip. And there are also different types in it, like epidermal type, dermal type, and mixed type, or it could be a centrofacial, a malar type, a mandibular type. So there are different types of melasma, and this is again a hormonal type. So, and this is not like, and this is also, we have another pigmentation type which is similar to melasma, which is called chloasma, and this is seen in pregnancy. In pregnancy, because of the increased level of hormones, the progesterones, the the increased hormones are responsible for this pigmentation. Because as in, like, the pituitary gland will not only respond to those progesterones which are released during pregnancy, so it also stimulates the MSH, which is called the melanin stimulating hormone. So what happens is, when the pituitary gland is responds to these, like, the hormone levels during pregnancy, in that case it also stimulates the melanocyte stimulating hormone, and this is responsible for the increased pigmentation which is seen around the neck, or on a line which is seen on the midline of the body, and increased pigmentation, like some people have melasma like condition on the face. These things usually subside by the end of 3 months after delivery, because these hormones, they become normal by the end of 3 months, and along with this melanin content or the pigmentation which is caused due to pregnancy will subside. But in case of melasma, it is a different condition. It usually occurs in middle-aged females, also in males, but most common in females. And you see that the pigmentation is present as in cheeks, nose, forehead, and the upper lips. And in these cases, you need to differentiate whether it is an epidermal or dermal type. And epidermal type is usually responsive to normal treatments or to lasers, but dermal type is little difficult to treat. So these are the types of pigmentations we have, and we need to identify what type of treatment should be given and do we really need a quick action against it, or you can wait and respond. So these things should be taken into consideration, and in these cases we have a different set of treatments for it. Like in every pigmented condition, sunscreen is a must. A broad spectrum sunscreen with UVB protection 30 is enough, as well with a UVA protection is required. And along with this we need depigmenting creams. And in case of melasma, there was a regimen called Kligman's regimen, and which is even being used now. But because of the misuse of the medication, people are suffering from a lot of problems like the excessive pigmentation, which is caused due to the long-term use of certain medications which are present in this regimen. This regimen consists of hydroquinone, a steroid and a retinoid. So these are usually to be used for 4 to 8 weeks, not more than that. So once a patient responds to treatment, it should be tapered and stopped. But patients, what they do is they continue taking the same medicine because it has worked for them previously, and because of that they are suffering from side effects like ochronosis and steroid induced side effects like atrophy of the skin, and the capillaries or blood vessels which are present become more visible because of the atrophy of the skin over it. So these are the common side effects of these medications, and they should be taken only under the supervision of a dermatologist. And along with this, we use other formulations like kojic acid, alpha-arbutin, licorice extract, retinoids, azelaic acid, and several other combinations are present. These could be either a plant extract or a fungal extract, or many. So they are derived from either plants or animals, and they mainly target the tyrosinase enzyme. The tyrosinase enzyme, which is responsible for the formation of the pigment in the body. And so these creams are mainly target this enzyme, and we also use retinoids. Retinoids are, what they do is they decrease the turnover of the keratinocytes. So with this the skin becomes thin, and whatever the medicines which are using along with it, they act better, they penetrate deeper and with a better efficacy. And along with that we also have azelaic acid. So azelaic acid creams are especially used even in post-acne conditions. Some people, they pick the acne, or it could be a deeper nodular acne which spontaneously heals with some pigmentation. So in such cases azelaic acid preparations are usually good. And in cases like melasma which are not responding to these regular treatments, we also use tranexamic acid 250 to 500 to 750 mg for 3 to 6 months, and patients usually respond by the end of 2 to 3 months. And this is like it should be used for minimum period, and the people are usually getting good results. And along with this, people who are not even responding, or those who recur after the using the tranexamic acid, we have further treatments like lasers, which are IPLs, or it could be a Q-switched Nd:YAG laser, which is especially good for this type of pigmentation. And in Q-switched Nd:YAG lasers, we have different probes again. For tans we have, for regular rejuvenation we have the probes, and also the for the tattoo removals for melasma. And melasma is really a tricky disease to treat because we need to differentiate them whether it is an epidermal or dermal type, and then use the parameters properly, otherwise there is a chance for permanent pigmentation. So there are several things which needs to be considered, and you need to take advice of a dermatologist who is a qualified dermatologist, and so that you will be guided properly, and the treatments, the regular conditions or the normal conditions which you can wait, or whether it is a condition which really requires treatment. Thank you.